Thank you so much, ma'am, and AIOS ARC for giving me this opportunity. So after listening to all the great speakers, so this is one message to the general audience, like how do you get to that level? So the basic thing is how do you actually start building on how do you start doing a complicated case? So it's a very simple kind of a thing. Clearing the visual access, a beginner's guide. So we'll start with a few cases. As an anterior segment surgeon, you have cases like this. Case 1, pseudophakia with posterior synechiae, an updrawn pupil, 618 vision. I initially go and attempt to break that posterior synechiae with the OVD, and then I go with the iris hook and iris repository, I'm sorry, and go behind the iris and make sure that I disengage the iris from any kind of pupillary, the synechiae which I try to stretch the pupil, and just to make sure that I have the visual access clear. I have the anterior vitrectomy cutter with me. I do it. On all these are anterior segment surgeons armamentarium. I get a 6-6 vision and the visual access is clear. I get some amount of confidence, so I can go to another case wherein we have an adherent leukoma with subcapsular cataract, 624 vision. Surprisingly, the pupil dilates very well. It's an uneventful cataract surgery. And we actually begin to wonder, is this the same patient? Doing all steps meticulously, making sure you put in an aisle in the bag, and I try and break the anterior adherent leukoma, which I am unable to. Again, my vitrectomy cutter comes into play. This time I'm more adventurous, so I create a huge opening. I don't have the idea what to do, but then the patient is 6'9", and then you come to these cases like posterior synechiae, pupillary membrane with calcified cataract. Herein, your incisions have to be very precise for your iris hooks, your main as well as the side port incision. I'm trying to break the pupillary membrane with the iris repository. Then I use the varnish so that I can have some kind of an opening. The iris repository again comes into play. I want my hooks to be perfectly aligned. Yes, at times we would keep on needing these small instruments, and these all instruments are there with the anterior segment in their armamentarium. We just tend to block it. Second is, once you get a decent opening, I try the capsulotomy with the capsulotum, then with the rhexis forceps, and finally with the varnish. I'm able to get a decent opening. And let's try the phaco. I'm able to take out some pieces, some part of soft lens matter, but I'm unable to go behind the calcified capsule because the visualization is not very good. So what do? Let's try the bimanual. It seems to be ineffective. Now, this is at one point of time, you feel like, why did you ever try and get this case? I mean, you could have referred this case. But this is where all the people who have talked before me, the attitude really is very, very important. So I said, let's try the iris repository again, try to loosen the lens matter. Somehow, I don't know, let's try the bimanual again, literally throwing the kitchen sink at it. It was not working, but somehow some amount of lens matter comes out. And after 45 minutes of hard labor, I am happy and so thrilled to see that red glow. And literally everything starts coming out. So the take home message here is, whenever you want to do any complicated case, start doing simple cases, which you don't need to bother an updrawn pupil or just an adherent leukoma. Why do you want to bother about that? Most of the anterior segment surgeons wouldn't try and touch that. Start doing those cases. Once you start doing these cases, you start getting confidence. With these cases under your belt, you are able to do that. I went a step further. This is one thing I would be court-martialed for. I made a neck and I tried to pull it. I had been playing with this capsule since an hour now. I had very great confidence that it wouldn't give way, and was literally talking to the capsule, saying it don't come out. Luckily, it didn't. I was able to put an foldable implant, and I went behind the IOL, and I was able to do the OVD wash along with some lens matter. I didn't want to do the polishing. Why? Because I was not wanting any kind of a PCR now. And finally, this case ended up with around 612 partial vision from PL+. So my take-home message is, try using every accessory of your machine. Initial hiccups are expected, and never say die. Wear that attitude. It really matters. Thank you so much.
Thank you, Rahul. All three videos were very nice. Really nice. More as a theoretical discussion, I will not question you at all. But the second case, the way the pupilloplasty is being discussed in all platforms, maybe that second case you could have done a pupilloplasty on hindsight.
Yeah, ma'am.
Third case, I wonder
I do
if
understand.
you could have used a vitrector to, because it was so calcified, to get an opening initially. Maybe. You did very well, but just a thought. Any other questions?
I just wanted to know, Rahul, for the benefit of the people, when you are making a pupil with the help of vitrector, what would be your settings? I mean, they are different from what you do when you're doing an anterior vitrectomy. If you could just highlight that part.
My settings, I mean, the cut rate is maximum. I have a Centurion, so 4,000 was my cut rate, whereas my vacuum was around 150, but then the cutting was good enough and I was able to make sure I do that. And the aspiration flow rate was hardly any, 10 to 15. That's it. And I just want to stress on this fact that it's very important that you start doing these cases initially. I do agree that the first case I would have tried many other things. Even in the second case, a pupilloplasty would have helped a lot. But then those are our initial cases, and you tend to err on the side. You want to be a bit more safe, and then you end up, and then once you see the slit lamp on the day one, you feel like, oh, you could have done that also. But then it's very important to start trying. And the essence of this whole video, what the message, the take-home message is, keep trying, start trying at least. Because most of us would not touch these cases, and we would say, let's refer the patient to a higher center or to a center wherein they have a vitreoretinal backup. All the three cases, obviously the third case would have been, I mean, you could have had a rent, but the first two cases you could have done it, and most of the ND segments would be able to do it. That's my take-home message.
Thank you very much.
Nice. Just one comment. I mean, nice videos, yes, Rahul. I mean, all the best to you. Since Namrata specifically asked this, I mean, when you are cutting this iris, maybe I would use the PI cut mode, especially since you have a Centurion, because you were telling about the vitrectomy settings. With that, it's a little more uncontrolled, even though you get only one cut at a time. If you use that mode, then you will be able to snip away the iris in a much more controlled manner and just create the kind of opening that you want.
Reduce the cutting rate.
Rahul, I'll just
I think I agree with Dr. Ramamurthy, what he's saying regarding the settings. Yes, sir.
Rahul, good videos. The only thing is that at times doing a vitrectomy or using a cutter to cut away the sphincter of the iris is not the best idea.
Yes, I do understand.
There is a retention of the constriction, even if it is an irregular one, there is a retention. So you are sacrificing it as if it does not really matter. I would have tried to disinsert from the top and try to make the pupil round rather than cutting it away at this thing. We used to do complete iridectomies earlier. So see, that's gone totally out of vogue. It's similar to actually cutting away the sphincter. So if you can preserve that, you would be able to preserve some amount of the action of the
Actually, if the vision was good preoperatively before the cataract developed, there was no need to expand the pupil. I mean, especially if you had enough amount of optics in that area.
Well, his pupil was very
I think there's one very useful test which you can do again anecdotal, and that is you can put pilocarpine and see what is going to be the status at the end of the surgery as to what would be the status when the patient, when the pupil is no longer going to be dilated. This works well for these cases and also works well for cases where corneal opacities are present, because then you can make out what is visual, what is going to be the status post-operatively.
We constructed the pupil, ma'am, on table. Yeah.
But very difficult set of cases.
Yes, Namita?
Very difficult set of cases. The last one was very tough.
Very good. And wishing you a great future.
Thank you, ma'am.
Going on to our next speaker,